You're listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
In today's episode, Dr. Matthew Martinez welcomes Dr. Steve Ommen to discuss the newly unveiled Hypertrophic Cardiomyopathy guidelines. From new medical therapies for obstructive hypertrophic cardiomyopathy to updates regarding the recommendations for HCM patient exercise, and new insights on sudden cardiac death risk stratification, these two experts break down some of the crucial information contained within the new guidelines, while also highlighting the fundamental similarities and differences between previous guidelines and this newest set. But what are the actual ramifications of these new guidelines to those affected by HCM in all age groups? Join Dr. Martinez and Dr. Ommen as they say goodbye to the old and hello to the new. Let's get in the thick of it.
Welcome, Dr. Ommen.
Yeah, Matt, nice to see you. Are you still down at ACC having a million meetings a day?
No, thankfully I escaped Atlanta and I'm back home. Now having a million meetings back here. So yeah. We're excited to finally be able to talk about this guideline, which it really is an anticipated guideline because there's been a shift in how we manage guidelines.
Yeah.
So in the old days, right, these were 5 to 10 years separated. Now I had the pleasure of watching you reorchestrate the 2020 guideline and now the 2024 guideline with an expectation that the next guideline might be 14 to 18 months from now.
Yeah, this is really a change from the Joint Committee on Clinical Practice Guidelines, which is members of both the American Heart Association and American College of Cardiology that oversee all the guidelines. And they really want to make these documents nimble and living and essentially try to update them whenever there's new evidence that would impact recommendations. And so we are the test balloon for that. And we convinced them of that because principally, the FDA approval of mavacamten for the treatment of symptomatic obstructive HCM. And so we said, why don't you, we're going to have just a few changes, let us do it. And so the idea here is not to tear the whole previous guideline down and rebuild it, but to update recommendations where there is new evidence needed supporting a change. And it does make the process generally quicker. And again, as they get their systems in place for this, I think we're going to see the guidelines updated on a more regular basis using this methodology.
I think it's really important, right? That way the guidelines reflect what's really happening in clinical practice so that we're not saying, well, it hasn't reached the guidelines yet, but this is how we do it.
Right. Yeah, and unlike in the past when they used to have focused updates on subtopics of a disease, it was hard for readers to kind of know, was that in the original guideline or was it in the 2016 focused update? So the idea is they're just going to republish the whole thing and highlight where the changes are. So whatever the most recent publication of the guideline is the most recent publication. And you don't have to go back and into history to find out, well, this one didn't mention exercise testing, for instance, or whatever. So yeah. I think it's a really good effort. It's been on the works for a long time, and I think we're the first one to kind of go through the process with them.
Well, I think it's necessary. I think you're the right man for the job. This was a tough task. You segued into it. Let's dig in.
Yeah.
So I think first and foremost, let's talk about medical therapy for obstructive hypertrophic cardiomyopathy. What's new?
Yeah, absolutely. So yeah, we already mentioned, so mavacamten, it's the new kid on the block. It's the talk at all the meetings, continue to have a lot of studies. And importantly, in the world of HCM, obviously these trials of mavacamten really represent the first randomized controlled trials for therapies directed specifically for HCM. And so that's super exciting from a scientific academic standpoint, but also for our patients that we're now getting therapies that we aren't just adopting, but are designed to treat HCM.
Absolutely. And this is a lift for the community of HCM. As I've said before, probably never been a better time to be an HCM doctor, never been a better time to be an HCM patient. Tell me what the guidelines are going to teach us about how to use mavacamten. What does the data show us?
Yeah, so the approval of mavacamten is really based on the Explorer-HCM trial and the Valor-HCM trial. The Explorer-HCM was the initial one, 30-week trial, mostly NYHA Class 2 patients for 30 weeks. There was a pre-specified endpoint of an improvement of VO2 of 1.5 and an improvement in NYHA class. And the results of reaching that pre-specified endpoint are somewhat modest. 37% of MAVA patients achieve that versus only 17% in the placebo group. But when you look at every other subparameter in that study, everything was on the positive side. BNP, gradients, all those. There wasn't a single thing that trended the wrong way, except for there are some patients for whom this agent is a potent negative inotrope and it suppresses the ejection fraction to less than 50%.
Yeah.
Valor-HCM was more symptomatic patients and again showed similar hemodynamic results. It showed that patients' gradients can be suppressed by this drug to really acceptable levels. And when you put those two studies together and you look at the patient-reported outcomes, so their NYHA class or their Kansas City quality of life scores, you can kind of come down to about 30% of patients in those trials got a lot better. And another 30% of patients got a modest improvement, and 30% of patients just don't seem to respond. And so we have put it in a place in therapy where you still use non-vasodilating beta blockers or non-dihydropyridine class calcium channel blockers as first-line therapy because they're cheap, available, easy to use. If those fail, then you have options for your patients. The options historically have been disopyramide or septal reduction therapy, but now we have disopyramide, mavacamten, or septal reduction therapy. And that's an important thing to have in that mix and discussion.
So still class 1, we're going to start with non-vasodilating beta blockers titrated to effectiveness or maximum tolerated dose, right? So you don't have to drive it all the way to a heart rate of 45 before you tell somebody that they're done, right?
Right.
Or using non-dihydropyridine calcium channel blockers, also a class 1.
Yep.
So it's an or, not an and, right? That was an important distinction, I think, this time, both class 1 recommendations. And then adding on potentially myosin inhibitors in adult patients, at least for now.
Yep.
That and this is all in symptomatic obstructive hypertrophic cardiomyopathy patients, right?
Correct. Symptomatic obstructive HCM patients. Yeah. So, and I think it's important, again, for if there are people watching or listening to this podcast who aren't as familiar with the use of the drug, while we don't cover it in detail in the guidelines, the approval comes with what's called a risk evaluation and mitigation strategy because of that drop in ejection fraction in up to 10% of patients taking the drug. And so it's distributed through specialty pharmacies, can only get prescriptions refilled a month at a time. At initiation, we have to do an echo every month for the first 3 months to make sure that the patient isn't overly sensitive to the effects of the negative inotropic action, and then every 3 months for as long as the patient is on the agent. So there are some logistic challenges for patients and for provider teams alike.
For sure.
So that's important for people to understand. It's not as easy as prescribing metoprolol for our patients.
And clearly the focus is on mavacamten. It's currently the only FDA version of this. And that's also why it is a class 1 indication, but it's not as a standalone drug yet because we don't have the data for that.
Right. Yeah, we don't have data going right to mavacamten as first line agent. It's also, it's a brand new drug. It's got a price tag to it that is higher than the old generic drugs. So I think it's prudent to try those. But now patients know that there might be an option if they're not interested in having an invasive procedure done to treat their symptoms.
So we've had good results with it. I know you've used the drug as well. And I think the way you framed it up is right, that it's the patient choice. It is the provider designed to utilize this in the way that the data has taught us how to use it.
Yep.
And then from there, then you can consider whether or not disopyramide is another option.
Mm-hmm.
We know that it can be used safely with mavacamten and those folks who may need both. In a small population, we have that data studied. And then, of course, there's still a role, right, for alcohol ablation in surgery, or should we fire the surgeon, Steve?
No, I don't think so. I mean, if you look at the overall success rates of these therapies, disopyramide in the case control study from our colleagues in New York, was successful over a 3-year observation period in about 60% of patients, meaning they didn't feel a need to escalate there during that 3-year window. For mavacamten, depending on your definition of success, 30 to 60 or 70% success rate. For surgery, that success rate's 90 to 95% or better when it's done at an experienced center. And for ablation, it is more on the 75 to 85% range at an experienced center. So patients sometimes want to get the higher success rate, and also some patients don't want to or can't tolerate medication. So we're still going to need these procedures for definitive options and for patients who are intolerant or unresponsive to medications.
Certainly childbearing age, all of those things go into this discussion, right? And I think this is really going to aid the patient in being able to make some important decisions. It's the first one. It's certainly not going to be the last one. As we said, there's going to be some shifts. Stay tuned. In a year or two from now, we may have an update that changes this whole process, standalone, add-on medicines, maybe a whole nother class. Just depends on what happens.
Yeah, that's right. And I think that now that the drug is being used outside of the confines of the clinical trials, we're going to start to get that experience that allows us to do better case selection. Which patients are definitely going to respond to this agent? Which ones are going to need to go to one of the other options because it's just not it might be this more severe gradients or the younger patients or something. We don't know that yet, but we're going to learn that as we get the long-term extension trials and registry data from all of our centers that are using these. And so I think it's going to be an important 5 years as we start to refine and optimize the role for these new class of medications.
And although there are some evolving data on non-obstructive HCM, we didn't address that. There's not any published data that we're aware of that would have changed the way we would approach non-obstructive HCM at present. True?
Mostly true. So there, we did add the one recommendation for gene positive young patients with very mild phenotypes that valsartan may be considered because there's some data that shows that it prevents the progression of a composite endpoint that's a lot of biomarker composites, those types of things. So, but for symptomatic non-obstructive, we didn't make any changes to recommendations. But as you said before, this is an exciting time because there are a lot of clinical trials going on that will influence the guidelines in the next iteration, undoubtedly.
No question. All right. Anything else about medical therapy, specifically around mavacamten, that are going to be changed, or can we go on to topic 2?
I think we can go on to topic 2.
Okay. So big changes in moderate exercise. So tell us about how the exercise guidelines changed. We're sort of down one section now. Now we're in lifestyle changes. Yep. What was addressed?
Yeah, so the biggest thing is that we had new data that came out mostly from the LIV HCM trial that showed that based on patients' reporting of their activity levels, whether it was mild up to, and we'll talk about what vigorous means, but there was no signal for increased advent rates either direction in terms of what we see for HCM-associated outcomes. So based on that, we felt more comfortable saying that for your average patient with hypertrophic cardiomyopathy, we can now encourage them. It is reasonable for them to participate in physical activity just like the rest of us are supposed to get. Low to moderate intensity, most days of the week. We can all talk to them about that. So we've made that now a class 2A, correct? Am I remembering that right? Yeah, it's a class 2A. Yeah. We left the competitive athlete discussion at 2B specifically because while there were some high-end athletes in those studies, it's not a large number of them. And the intensity of exercise that a college athlete, high-end high school athlete, and certainly professionals put into their workouts it's kind of like the difference between an expert myectomy center and a high volume center. There's a kind of a quantum change there. We just felt like it was important to say that's a discussion that may be considered, that's class 2B language, when they talk to a cardiologist who really understands HCM and really understands the stresses of sports training.
Yeah. So I think, when we always think about data, we think about, does my patient fit into what was studied?
Yep.
And you hit on it nicely. The Live HCM is a mostly older group. Average age was around 40, something like 75 to 80% were over the age of 25. The majority of them were white athletes. And it looked at vigorous athletes, right? It looked at an hour to an hour and a half of exercise on a weekly basis, which is terrific for the achieving the exercise fitness level. We can now have that conversation with patients and say, not only should you, but you can do it safely, and you ought to be. This is something we ought to be having with our patients every time we see them, right?
Yes, absolutely. Yeah, we should be encouraging people to be active.
Just like we do with everybody else, right? Telling them that their weight, their diet, their nutrition, and their fitness level have impact. As you well know, an older study from you and Paul Saraja from years ago looking at fitness level in those with HCM, we know that they have a prolonged survival and a reduced risk of heart failure. This is an important component, and I really think solidifies that 2A recommendation.
Yeah, exactly. So this is a world that you work in a lot with your sports hat on. You want to talk some more detail about what we mean by low intensity, moderate intensity, and vigorous intensity?
So we wrote about this for ACC.org, and there are some good references there that I'll turn the listener to as well. But when we think about mild exercise, you're talking about exercise that you can still have a brief conversation. It's in that 3 mile an hour range where you're a little bit breathless, but still able to have a conversation with the person next to you. And then as you move into moderate exercise, now you're talking about a little sweat on your brow, have trouble having a conversation, a few words can get out. You can no longer say, sing a song or sing a sentence when you're doing that. Now you're into moderate. And then vigorous is when, there's no talking, it's time to focus, and then it's sustained. And then I would argue that beyond that is, of course, that elite level athlete, when you're pushing yourself to a point in which you are stretching what others can do. And we still need more data in that realm. We published a small publication on that, looking at those elite athletes. And I think we're moving in the direction of knowing who might fit into that category. But I would say you have to move into this area with some caution, right? This is why it really is a strong 2B, because this might not be for everybody. This is a conversation with folks who are comfortable with both the athlete and in that HCM patient, and recognizing that even low-risk patients can have complications, including sudden death, and that it requires a comprehensive discussion with the patient, a comprehensive discussion with the entity that they're playing for, making sure that there's a safety plan with an emergency action plan and ease of accessibility to an AED. It's more than just saying we risk stratified you, we think your risk is low. Right. There's a whole lot into that, right?
Yeah, the emergency action plans are super important for the training facility and the competition facilities for athletes for all sorts of reasons, but HCM is one of them for sure.
Yeah. So I think a move in the right direction. I love how the data helped guide you in terms of saying what could be a 2A, what could be a 2B. And again, we're going to know more in the next few years as we're now allowing, with some caution, some perimeters, folks to do this more and more. I think we're going to be able to get a better handle on this, I hope, with some more data.
Yeah, it's interesting, and then you get the patients who come to you. They're the middle-aged guy who says, "Hey doc, can I want to still want to play rec league hockey with my buddies? Can I do that?" And that's a little bit more challenging because if they're middle-aged, they likely haven't stayed at the peak of athletic fitness the whole time, and they're trying to get back in shape. But I usually say it depends, and it depends on how you approach your rec league hockey game. If you're just out there kind of cruising around on the ice and you kind of pass the puck back and forth and, it's kind of fun, that's one thing. But if you're the kind of personality who's going to win, you need to win. People win and succeed in sports because they start denying the stop signals from their body. When it's your body's screaming at you to stop because you're short of breath or your heart rate's too fast, you're getting dizzy. No, I can make this goal. We don't want our HCM patients doing that. So it's a counseling session for the more weekend warrior person who wants to maybe get a little bit more competitive, how you counsel them through that.
And obviously shared decision-making was a huge part of the 2020 guidelines. It remains a paramount in the 2024, as it does for all aspects of HCM care. But I think more to come in the future with this. It's an exciting time for us to continue to learn more about this.
Absolutely.
So let's shift gears now to atrial fibrillation, maybe the most challenging part for me with regards to HCM care, not with as it relates to anticoagulation. That's a little easier for me to wrap my head around, but help us with monitoring. How often, who's at risk, what we change?
Yeah, so there's been a couple of risk tools, not risk for stroke, because we know that having HCM, the risk for stroke is about 3%. It's equivalent of having a CHADS VAS2 score of 3, so anticoagulation recommended. But there's now risk scores that tell you how likely is this person to develop atrial fibrillation in the next 2 or 5 or 10 years. And if the patient scores higher on those scales, then you might consider doing more often prolonged ambulatory ECG monitoring to look for episodes of subclinical AFib.
Yeah.
Now, obviously, we're going to be doing ambulatory ECG monitorings annually if patients don't have defibrillators, doing their sudden cardiac death risk assessment, but you're also looking for AFib. And so using these risk scores, if a patient's high risk for that, or they have a super large left atrium, or they have funny palpitations that make you concerned, well, you ought to be doing this monitoring just to make sure we're not leaving a patient unprotected from stroke prophylaxis.
So that goes into that shared decision-making conversation, right?
Absolutely.
How concerned the individual might be, and then your own individual concern. You might be doing this more frequently in a patient who you think has an enlarged left atrial size, or they have obstructive sleep apnea. They've got other risk factors that you're trying to still manage.
Exactly. And then, the challenging part for me, Matt, and I don't know about you, is you get someone who has some AFib and it lasted for 2 hours.
Yeah.
One time. And so again, just like in non-HCM atrial fibrillation, the data is pretty clear. The guidelines are very clear. If they have at least 24 hours or more of AFib, that anticoagulation is the right pathway. But for 5 minutes to 24 hours, we're kind of wishy-washy because there are so few data to tell us what to do in that. So that really does come down to your clinical judgment, the patient's concern, hesitancies around anticoagulations or not, drug-drug interactions, all these kind of things have to be taken into making a decision in those people who have transient subclinical AFib.
And this goes into this, again, puts my sports hat on, where they are, it's an individual who has 4 hours of atrial fib, or 8, 10 hours, something like that. Otherwise, they obviously have hypertrophic cardiomyopathy, and they're cyclists,
right?
Or they're a downhill skier. How do I have this conversation with them about blood thinner where they say, wait a second, doc, now I'm at risk to bleed when I participate in a sport, a few hours worth of atrial fib. How do we sort this out? Shared decision-making is all part of that conversation, right?
Yeah, absolutely. Yeah, and obviously they all need to be wearing helmets, and
For sure.
It's in ski jackets, but I've also seen new cycling clothes that basically have built-in airbags. When it senses you falling, it inflates. Now, those aren't ubiquitous, they're not cheap. But if you have someone who's really going to do these things, if it's someone who falls a lot, if they're a mountain biker and that you're out in uneven terrain, you might start having those conversations with patients.
And nowadays, everybody's got an ambulatory monitor of some kind, right? Whether it's their watch or their Garmin or whatnot. And so we are fielding all of those conversations, as you point out, these elite level athletes that are participating in mountain sports or in potentially collision sports, how we handle that, right?
Right. Yeah, and I do think that's another area that we're going to see influence our guidelines in the coming years, and that is all the wearable devices and all the sensors in the devices are getting better and better all the time.
No question.
How are we going to incorporate those into life risk assessment for our patients with HCM, and does it influence some of our care decisions, our discussions we have with patients? I think that's also another very exciting era.
And I think if you're looking for an area to help us out with, that is an area where it is ripe for guideline need, where there's a gap, where we don't really know that how to utilize those better. If there are folks out there that have an interest, this is an area that needs some guidance and some data.
Yep. Completely agree.
Let's change gears again. Tell me about what you and I refer to as splitting up the kids from the adults, right?
Yeah, so it will look in the guidelines like there's a major change in sudden cardiac death risk stratification, because there's a new section on risk stratification for adolescents and children. That is really, there's not a lot of content that changed. We had them lumped in the prior guideline, but because of some appropriate word count restrictions in order to make these guidelines more nimble, we had to separate them out because it allowed us to keep the recommendations and the recommendation text small enough that they can be rapidly changed. And so we just teased out the kids, made them their own section. The one change that did come there is similar to the HCM risk calculator for adults, which was mentioned in the prior guidelines to be used as part of shared decision-making. There are now 2 risk calculators for sudden cardiac death in kids that can now be considered as part of risk stratification for those children and their families in a similar vein. So those are added to the guidelines. But it's not really a huge content change compared to 2020.
So this is important because obviously risk stratification in that group is different. The Z-score comes into play. What you and I would consider a high risk of 30 or 31 millimeters could be dramatically lower in a younger individual with regards to risk stratification and potentially an ICD, right?
Yep, correct. Yep. And then and it's particularly important because, the younger the individual is, the patient, there's all issues about the body growth, have to grow. All these kind of things. And so using tools that helps the families understand that patient's specific risk, the best way we can, these are all estimates, is going to be helpful for those discussions and making those important decisions.
Absolutely. This is the conversation I often have with teenagers who are in the office who don't quite meet the absolute cutoffs, but they've got a 24 millimeter thick wall. They've got a little bit of scar, and maybe they are 14 or 15. Boy, they sure look like a full-grown adult, but they're not quite.
They're not. And we know that things like non-sustained ventricular tachycardia or 24 millimeters of wall thickness mean a lot more if the person's a teenager than if they're a 60-year-old.
That's right.
So the calculators kind of account for that and help us use continuous variables continuously and again give these estimates and it just helps. Many patients come into our offices and they've heard that sudden cardiac death can occur, and we have a human nature to over predict how likely we think this thing to happen. So they think I've got a 50-50 chance of dying suddenly. Well, that's rarely the case.
Right.
And so it helps calm them down, but also put it in context, because if your risk is 5 to 10% for a cardiac arrest in the next 5 years, well, that's meaningful to people. So
in that regard, I really like the calculator because it helps me frame a number around it.
Yep.
And then I have to then try and give them some scenario that helps them better understand what that number looks like and what it means to me. If 2 or 3% to them doesn't sound like a lot, then I start kind of trying to frame it up about what a risk might look like in another part of life, or even correlated to surgery, what the risk might be for what most people think. I often use open heart surgery. Well, in his case, his risk would be this.
Right.
Well, that's really low compared to what I thought. And that helps frame it up for the patient. Again, shared decision-making, right?
Yeah. So the way I approach this, and I guess we should reiterate for the listeners and watchers. So the class of recommendation, the class 1, 2A, 2B kind of designations in our guidelines are predicated on the presence of specific risk factors. And then we recommend using this tool as a way to fine tune that discussion with the patient. So I usually tell patients if they have one of the risk markers, that having one of these risk markers makes you eligible for an ICD. And we have 3 layers of eligibility. We have class 1, patients, it's secondary prevention device. We have class 2A. It means it's reasonable for you to get a defibrillator. It also means it's reasonable for you to say no, thank you, if we have a discussion about this and you understand the implications, et cetera. And class 2B means it can be considered. The role is not clearly defined, but with the right level of patient anxiety about their risk or physician anxiety, you can consider putting in a device. And then we further refine it with that number. So I use both the levels of eligibility and the point estimate to help patients kind of get their arms around how much risk they're carrying.
And I think for the listener, if you haven't looked at the 2020 guidelines, there are some changes to risk stratification. The hypotension, as an example, with exercise-induced hypotension, fell off the risk stratification model. Some new changes like apical aneurysm and a drop in ejection fraction under 50, we now include as one of those 2B risk markers to talk to the individuals about.
Yeah, and I guess it's important, since we mentioned EF less than 50 before under drug therapy with mavacamten, we're talking about a persistent non-resolving ejection fraction. If a person's ejection fraction drops because they went on mavacamten, that doesn't mean they buy themselves a defibrillator. We discontinue the drug, the EF comes up, and they don't have to get a defibrillator because they had a drug-induced drop in their ejection fraction.
Absolutely. And even within that criteria, there's going to have to be some more refinement in the future. Yeah. Size of the aneurysm, how long, how low, is 48 the same as 42? Probably not.
Probably not.
So certainly some more to come. Other things.
So that's one of the challenges with guidelines, right? I mean, so we are asked by the community at large to put numbers. So what's the cutoff? And so 49 and 51 are not conceptually or biologically different, but because we need to somewhere draw a line in the sand, then we're left with that conundrum. And that's where you have to step back and recognize that all of these cutoffs are at some level arbitrary, just trying to point you in the right direction. And then you have to be a doctor and talk to your patient and put it all together as a holistic view of what's going on with that patient.
Absolutely. I have to say, this has been an incredible conversation. Thank you for agreeing to do this podcast. This is going to come out right as those guidelines get published, just after they get published at least. So this hopefully is going to be an aid to those who are now reading the guideline, and for you to have pointed out where the areas where you think that are new and really need extra attention for those that are whether either new to the space or are expert in the space. This is where one should focus. Thank you for joining us, Dr. Ommen, on In the Thick of It.
Thanks, Matt.
That was Dr. Matthew Martinez and Dr. Steve Ommen. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you again soon on In the Thick of It.